but we're going to talk about osteoarthritis and how can you tell the difference between that and rheumatoid arthritis. And osteoarthritis is a wear and tear arthritis, and we will all have some form of osteoarthritis if we live long enough. It's just an inevitable thing. 20 million people in the United States have osteoarthritis, and it's usually the weight-bearing joints, the knees. It can be ankles and feet and hips, the lower back. But then you have another type of osteoarthritis. It's what they call a familial inflammatory type of osteoarthritis. And people will say, oh, my grandmother has hands like that, where you have the knobby joints. And the osteoarthritis is this distal joint and the middle joint. Okay, so we call these the PIPs, meaning the proximal interphalangeal joint. This is the distal interphalangeal joint. Whereas with rheumatoid arthritis, it's the MCPs, the metacarpal phalangeal joints, and the PIPs. So when somebody comes in, they're primarily PIP, you kind of have to go through a whole history and examine everything to try and deduce, okay, let's see, is that more of an inflammatory? So morning stiffness becomes very important. Come in. No, you just come right in. We're talking about rheumatoid arthritis and osteoarthritis and how you tell the difference. And so morning stiffness is a big feature with rheumatoid arthritis. And we'll have patients explain to us, how long are you stiff in the morning? And they'll tell us half hour, an hour, 2 hours. When it gets very prolonged, you're thinking more, this is more inflammatory, because osteoarthritis, you're stiff and then you get going and that's it. Do you stiffen up during the night? It's more of an inflammation type of arthritis. And then the presentation of pain. Do you have pain in the morning, or do you have pain as the day progresses? And a lot of times with osteoarthritis, pain more when you do something. So that's kind of what we're doing when we're talking to the patients and trying to figure out, okay, what are we dealing with here? Now, the thing about osteoarthritis is you wear down the cartilage. And I had my knee book here. What happened to it? I don't know. Anyhow, what happens is you start to wear on the cartilage. And what we see on X-ray is a narrowing of the joint space, because the cartilage space is getting less and less. Now, when you wear on the cartilage, the bone tries to repair itself by making more bone. So you get spurs. Okay, and then in the back, what happens is you have little joints here between the vertebrae, and these are called the facet joints. And they have cartilage. And when they start to wear, you start to develop spurring, and that spurring encroaches on these little canals where the nerves come through, and that's when they say, well, you're pinching a nerve. Okay? And so that's why when you have osteoarthritis in the back and you go into a grocery store, it's so much easier to get a cart because you're opening up those passageways and you're taking pressure off the nerves. Whereas if you're walking up a hill or up steps, you're in a more erect position, or going down steps, sometimes you're in a more, going up, you're probably more flexed. Going down, you're going to be more erect, and that's going to bother your back also because you're making those passageways smaller. So osteoarthritis it's progressive, and the treatments that we use for it, exercise is important. And because it's the exercise that lubricates the joint space, it's that motion back and forth, and that helps blood flow, and that's actually beneficial. Medication, we use NSAIDs, and sometimes you can't take NSAIDs because your kidneys or your GI tract, and that's when we take things like the Heal and Smooth, because these are mostly enzymes that you're taking because of the buildup of fibrin in the joint space causing the pain and stiffness, and that is fibrin, it kind of cuts away at the fibrin. Glucosamine, okay? Glucosamine, you can buy it. And how much should you take? Glucosamine is important because it's a component of healthy cartilage, and chondroitin is the other component of healthy cartilage. When you buy glucosamine, you want to buy glucosamine sulfate, not glucosamine hydrochloride. Glucosamine hydrochloride doesn't work, but it's you want the sulfate moiety, and it's not the type of thing that someone who has a sulfa allergy will be allergic to, okay? And then the chondroitin,
Which brand?
I look at the contents, and I look to see, is this glucosamine sulfate or hydrochloride? And I want to see it be 1,200 milligrams. I'm not recommending any one, because there's a lot of them out there. And then but they work best if you take chondroitin also. And you want, the chondroitin sulfate is a good one, but the chondroitin should be at least 800 milligrams. And interestingly, you get both of these in one preparation. That's not as good as buying glucosamine and buying chondroitin. And they say to take them apart is the best way. So you would take your glucosamine in the morning and the chondroitin at bedtime. That's probably the most effective way of getting good absorption of these components for your...
It was 1,200?
1,200 milligrams of glucosamine sulfate and 800 to 1,200 milligrams. No, wait, did I say 1,200? It's 1,200 to 1,500 of glucosamine sulfate, and then 800 to 1,200 of chondroitin sulfate. Okay? So that's all. That's very important too. Now, we also have, for the knees, we have the hyaluronate injections. And that's the series of injections where they inject, hyaluronate is the product that is depleted from healthy cartilage, and you have less and less. And so if you can somehow restore that, you get back the cushioning and the shear forces. Now, this is for the knees. I know some orthopedic surgeons use them in other places, but we do the knees. And I've heard that they might inject it in the shoulder or something like that, but I have not. And oftentimes these come in a series of 3, and you have to get 3 weekly injections. And those injections, you'll see the best benefit when you complete that series 4 to 6 weeks later, because right then, don't think, okay, this is the 3rd one, and I'm not sure I'm where I want to be. You may not be. It takes a couple more weeks, maybe about 4 more weeks, to see what the maximum benefit is. And if you get a benefit for 3 to 6 months, that's a good response. And insurance will allow you to get another set every 6 months. Some insurances every 3 months. And so, but there are different kinds. There are some that have lower molecular weights. There are some that have a high molecular weight. The one that has the real high molecular weight is Synvisc 1, and it's 1 big injection. and then the others have a somewhat lower molecular weight. Now, this Hyalgan is derived from rooster combs. Okay, that's where it comes from. So if you're allergic to chickens or eggs, I don't know, you know. In that instance, I use Euflexa because that's bioengineered in a lab, and we don't have to worry about getting it from roosters. Okay, so that the final option, we have our medication, we have our exercise, and the injections. Surgery is the final option, and surgery is very successful. And we have very successful surgery for knees, hips, now ankles and feet, shoulders, wrists. You know, it is very good. I have to say it. I have failed shoulder surgery twice. So, but I'm still working at it.
You never had it refixed again.
I don't want to be like this for 6 weeks. I can't blow dry my hair or put on makeup or anything. So, you know, and I've had hip replacements. My first hip replacement was 25 years ago.
Wow.
I need a redo.
Oh.
Okay. And the second hip replacement was 21 years ago, and that hip's still good.
Thank goodness.
So they can wear out, you know, if you're active and that type of thing. But so, you know, if you ever have any questions, I'm a poster child for this practice. So.
Did you get your knees done yet?
No, I don't need knee replacements. Isn't that good?
Yeah, that's good.
Yeah. But I think I need I think I have a meniscus here. I do have a torn meniscus. It was on the MRI, and I remember when I did it and everything, I was out with my grandkids trying to find a Christmas tree to cut down.
Yeah.
And so the orthopedic surgeon says, if that's what you were doing, I'm sure it'll get better on its own. Well, it hasn't. Okay, now rheumatoid arthritis, like I mentioned before, it's a very symmetrical arthritis, both sides of the body, as opposed to osteoarthritis. You might have one knee or one shoulder or whatever. And again, it's the MCPs and the PIPs. It can involve both the wrists. It can involve the shoulders, both of the knees, both of the feet. But the difference is there's an inflammation within the joint in the synovium. That's the lining of the joint, and it makes excessive synovial fluid. And it's an inflamed synovial fluid, and that starts to eat at the cartilage. And once it gets through the cartilage, then it starts to eat at the bone. And that's when we talk about erosions. And so this is an erosive type of arthritis that in this day and age, there's a lot that can be done early. And I send far less patients to surgery now with rheumatoid arthritis than when I started practicing 40 years ago. And, you know, the risk factors for rheumatoid arthritis, more women between the age of 20 and 50, more so than men. And a family history is important too, if there is a family history. But you really get the severe morning stiffness, you get red, swollen joints. And again, if we can start treatment soon, we usually start out, we might start with NSAIDs first. Okay, we might try naproxen, or we might try Celebrex. I like Celebrex because it's safer on the stomach and even the blood pressure than some of the others we found. And then if I see promptly that this is a rheumatoid arthritis, and how do I establish that? Well, by the exam, I look at the x-rays to see if there's any erosions, and I do blood work. And that's where I check for a rheumatoid factor or positive CCP. Those are the two biggies that if they're positive, that sometimes suggests this is going to be a more aggressive type of arthritis. And if you can start treatment early, you can really arrest the arthritis or slow it down considerably. And some of the medications we use, methotrexate is what we call a disease-modifying drug. Plaquenil we even use for this. It's a disease-modifying drug. Sulfasalazine, if you're not allergic to sulfa, Arava is another one. Those are what we call the disease-modifying anti-rheumatic drugs, the DMARDs. But the next class of drugs that we now have are the biologics. And we have to be more careful with the biologics because they can lower your immunity and make you more susceptible to infections. And we emphasize that if you have an infection, hold your biologic and get over the infection. And the nice thing now is that we can almost genetically predict what biologic is going to work for the patient. We have certain tests called PRISM, for instance. If, in the office, they'll say, we're going to draw a PRISM on you, and it will tell you if you're going to respond to an anti-TNF or if you're only a 10% responder. And what we mean by the TNF drugs are the anti-TNF drugs. We're talking about Enbrel, Humira, Cimzia, Simponi, Remicade, Avsola. Those are the class of the anti-TNF drugs. If the PRISM says, no, you're not going to be a great responder, and if you have a persistent high SED rate in CRP, we then look at Actemra or we look at Kevzara. Those are the IL-6 drugs. And then we also have the oral biologics now, like Xeljanz and Rinvoq and Olumiant. We have Orencia, another class of drugs. And so there's quite a huge number of them out there. And sometimes we run out, I have to say. I had a patient today that I'm scratching my head, and I said, I don't know, you've been on everything, But, well, I know I was only on this one drug for a short time, and I got a sinus infection, but I always get sinus infections. Okay, so we're going to try that drug again. And this time, we can try it IV as opposed to injectable because the dose is different. A lot of times I like to try the drug. If it's going to be a biologic and it's given sub-Q or IV, I like to go IV because it's weight-based. You're getting what you need. But those are the biggest distinctions. Again, exercise is always important if you can get the exercise in. If you have a joint that flares after you exercise, ice it, okay? Ice for 20 to 30 minutes. If heat is best as a warm-up, okay? And if you end up coming in the office and we do an injection on one of your joints, we'll tell you to ice it for the next 24 hours. Don't put heat on. Okay. Any questions?
Psoriatic arthritis.
You're going to have to come on Thursday. There's a whole talk on that.
Anyway, I understand that this curving is more psoriatic arthritis.
Well, let me tell you, there are 5 presentations for psoriatic arthritis, and one is an RA-like presentation, rheumatoid arthritis type. And let me see your hands. Do these joints bother you?
Nope.
But these do.
Not really.
They did.
This one a little bit.
Yeah, now
getting
we could see this in osteoarthritis. Remember I said it's a distal joint. And these are Heberden's nodes that you see from bone being produced as spurs. But again, with psoriatic arthritis, it can affect these also. So then we have to get down to, okay, let's see, do you have any psoriasis in your scalp? Do you have any behind your ears? Do you have any between the gluteal clefts? Do you have any in your belly button? Places that you may.
eczema, but not psoriasis.
And you're certain it's eczema?
That's what doctors said, but they weren't rheumatologists.
Were they dermatologists?
Maybe,
Well, sometimes it takes a biopsy to find that out. I mean, we even have good biologic drugs for eczema now.
The problem is I had cancer in 13. It was melanoma. They took it out. I'm fine. But so many of the biologics, I'm not allowed
Yeah,
to
that's a
take.
scary thing to have had and put someone on a biologic. Now, I have had patients who have had melanoma and it's remote, and I make them see their skin doctor at least annually, if not every 6 months, if they decide they want to try a biologic for their psoriatic arthritis.
And then it also can affect your feet.
Yes.
I won't show you, but my big toe here actually bends like that.
Does it? Yeah. Yeah. And that certainly can be psoriatic arthritis. So that can be a destructive arthritis on X-ray. Then you can have a type of psoriatic arthritis that affects maybe one joint or less than 5 joints. It's called oligoarticular, meaning less than 5 joints. It could be a knee and maybe a wrist and maybe a shoulder, but it's psoriatic in nature. Then you have the kind that it mimics ankylosing spondylitis and affects the SI joints and the spine. And in those patients, they can have a positive HLA-B27, and then we think, oh, gee, this might be more psoriatic spondylitis with a positive HLA-B27. And then you can have the type that mimics osteoarthritis, more of what yours, if you have psoriatic, this is mimicking a lot like the nodal osteoarthritis. Tough thing about psoriatic arthritis is there are no markers for it in the blood. Negative rheumatoid factor, negative CCP, oftentimes the ANA is negative, but we're now finding that there's a new test evolving called an ETA 14.3.3 that can be a marker for psoriatic arthritis. But the drugs work. And we have to find, when you have psoriatic, it depends on your skin disease. If we want to go with something that is more directed towards skin, or do we want to do something that's more directed towards joint? There's a huge armamentarium out there for psoriatic.
What is the biologic for eczema?
Well, one is Xolair, one is Dupixent. But usually what I'll do is I will check immunoglobulin levels and see if the IgE, which is the allergy type of immunoglobulin, if that's high, I might choose to talk to the patient about Xolair if they have eczema, and
I just get flares here and there.
Of eczema?
Oh, yeah. Especially in the winter. Yep.
Maybe we should check you.
Yeah.
But you're on Kevzara. We're not going to do two things.
Oh, okay.
You're not going to be on both of those.
No, I don't wanna
Where
go off of
you
that.
don't use two biologics.
I see.
Yeah.
Okay.
Yeah. Yeah. Any other questions?
Interesting.
Just a comment. Things have come so far. And
Oh my,
even
let me
10
tell
years.
you, in the last, all right, I've been in practice for 43 years. Now, when I came out, all we had for osteoporosis was estrogen and calcitonin. Now we have a whole slew of medications we can use for osteoporosis. For rheumatoid arthritis, we weren't even using methotrexate yet. It was just coming out. And then they had an oral methotrexate that was coming out. We didn't have anything else available for that.
Amazing.
I mean, I have seen it really revolutionize. And I
Yes.
oftentimes said, I'm waiting for when we can do a blood test and it's going to tell us which pathway is
Yeah.
the involvement. And it's getting close to that. It's getting close to that. We do the Vectra to check inflammation. And those of you who may have had inflammation in rheumatoid arthritis, we do, there's you do a scraping of the psoriasis, and it can tell you if the drugs like the IL-17s or the IL-23s, or which ones are going to work for that psoriasis now. I mean, we're getting close. Yeah.
Mm.
Yeah.